In this video, I shall talk about facial nerve palsy. The facial nerve is both motor and sensory nerve with autonomic functions. That's why it has three nuclei. The main motor nucleus lies deep in the reticular formation of the lower part of the pons and supply muscles of facial expression. The parasympathetic nuclei lies posterolateral to the main motor nucleus, and they are the superior salivary nucleus and lacrimal nuclei. Both of them receives afferent fibers from the hypothalamus through the descending autonomic pathway. The sensory nucleus is the upper part of the nucleus of tractus serratus and lies close to the motor nucleus. Taste sensation is carried from the anterior two-thirds of the tongue through the chorda tympani branch, whose axon synapses with the geniculate ganglion, which in turn synapses with the nucleus. Efferent fibers cross the median plane and ascend to the contralateral thalamus to the taste area of the cortex. Now, how does the facial nerve works? We have to know that the main motor nucleus of the facial nerves has two halves. The upper half of the nucleus innervates muscles of the upper part of the face, namely frontalis and orbicularis oculi muscles, while the lower half of the nucleus innervates muscles of the lower part of the face, namely the buccinator and orbicularis oris muscles. The upper half of the nucleus receives innervation from both cerebral hemispheres through bilateral corticonuclear tracts. However, the lower half of the nucleus receives innervation from only the contralateral cerebral hemisphere. Then, both roots of the facial nerves emerge from the anterior part of the pons in close association with the vestibulocochlear and the trigeminal nerve. And together with the vestibulocochlear nerve, the facial nerves enters the internal auditory meatus. At the bottom of the meatus, the facial nerves enters the facial canal. Here it expands to form the geniculate ganglion and give its branches, which is the nerve to stapedius, and also receive the chorda tympani branch responsible for taste sensation. Then the facial nerve leaves the skull through the stylomastoid foramen and enters in the parotid gland, where it divides into its terminal branches. Now let's clarify how to localize facial nerve palsy. First, supranuclear lesion, or sometimes referred to corticonuclear tract or upper motor neuron facial palsy. In this situation, there will be contralateral weakness of the lower half of the face, namely the buccinator and orbicularis oris muscles. Clinically, the patient will have flat nasolabial fold and a drop angle of the mouth of the contralateral half of the face. Note that the upper half of the face will not be affected since the upper half of the nucleus has dual innervation. Second, with a nuclear lesion, there will be paralysis of the ipsilateral half of the face, also called as lower motor neuron facial palsy. And because the facial nerve makes a loop around the abducent nucleus, there will be an ipsilateral abducent knob palsy as well. The third possibility is a lesion at the cerebellopontine angle. Here, there will be an ipsilateral lower motor neuron facial palsy plus ipsilateral vestibulocochlear and possibly trigeminal knob palsy, since these three nerves are close together. A fourth possibility is a lesion at the internal auditory meatus. Here the patient will have paralysis of the ipsilateral half of the face together with loss of function of the vestibulocochlear nerve, causing hearing loss. The fifth possibility is a lesion in the facial canal. In the facial canal, we know that the facial nerve gives rise to the nerve to stapedius and also the chorda tympani branch. So there will be paralysis of the ipsilateral half of the face plus hyperacusis and loss of taste sensation in the affected site. Finally, a lesion after the stylomastoid foramen will cause paralysis of the ipsilateral half of the face.